Thank you very much, Chair. I'd just like to quickly acknowledge my colleague Mel Medlin, who did most of the work on this program, and there are a couple of other acknowledgements being shown in collaborators for this important piece. Look, before I go into the topic, which is how we looked after COVID patients at home during wave 2 of the pandemic, I just thought I'd give you a quick 101 on Australia and Victoria. So here's the map. Victoria is bottom right. It's one of Australia's states. We've got about 25.5 million people in Australia, and about a quarter of them live in Victoria. That's quite important to understand our health system. So each state runs its public hospital health system, and in Victoria, they're not that different to NHS trusts, if that's useful. But a bit of an overview of the health system. For seeing your GP or specialist or for getting diagnostic tests done, the Medicare system does subsidise that. And for medicines, we have a pharmaceutical benefit scheme, which really does make a difference in terms of accessibility, and they are federally funded. Free hospital care is guaranteed to Australians wherever they are, but of course that means that waiting lists can be quite long for elective procedures and for outpatients. And about 30% of Australians, people like me, take out private health insurance. So private hospitals, which might be corporate or they might be philanthropic, they do about a third of activity, but about a half of procedures. So I don't know, about 11 million admissions in Australia each year. Victoria's a quarter of that, and 60% of those are in the public hospital system, and the private hospital system picks up quite a significant chunk of booked procedures. Victoria, again, just to get a clearer view, is about a quarter of everything in terms of activity. Okay, so with the COVID pandemic in Australia, we had in February the first cases coming in. We shut down travel from China quite quickly, but a number of cases came in from other places, and there was a bump which you can see on the left-hand side. And we did all right with that and brought in public health measures, and each state activated a system. And although we hadn't had outbreaks this virulent for quite some time, we got on top of it. And in July, we have a weekend called the Queen's Birthday. We had 2 days there with no cases in Victoria, and there was much rejoicing. However, wave 2 of the pandemic started hitting particularly hard our residential aged care sectors, and we got up quite quickly in the state of Victoria to 726 cases a day. That really was a rapid acceleration, and we hadn't had anything like this for 100 years. So then where are we? We had a number of problems to solve beyond controlling the pandemic, but the characteristics of where we were as a state public health system then was a massive rise in caseload and then healthcare worker exposure. So of course, once infectious folk are in an ED or in a ward, you have to furlough lots of staff. There was no vaccination last year. So those pressures on the health system are exacerbated. They're exponential because a number of staff have to come off. Our elective surgery, we had to crank it right back. And actually our private hospitals helped us quite a lot by picking up some of the aged care folk and looking after the ones who are unwell. Our privately operated aged care services didn't do that well. Our public health capacity, contact tracing, that was really challenged. But in particular, although I think we did quite well eventually on the public health measures, the impact of self-isolation, apart from the contact tracing bit, was quite difficult for many, many folk. As you're aware, COVID has a higher impact on vulnerable populations, so the management of concurrent diseases while people are stuck at home for 14 days, whether you've got atrial fibrillation, perhaps a mental health issue, a complex pregnancy or diabetes, managing those when you can't go to the GP and the pharmacy was difficult. In addition, there are welfare needs. And look, the anecdote I would share is the gentleman who, when he was diagnosed and notified, his flatmates asked him to leave, so he needed accommodation and he wasn't doing that well. So it's a difficult time for cases who are positive, notwithstanding the fact that for many of them the disease itself was manageable. What we had in our favour in Victoria was it was mostly a metropolitan profile. There were outbreaks in regional and rural Victoria, but they got on top of them reasonably quickly. So they were able to manage without really going into a kind of a frantic mode. Metropolitan Melbourne had most of the cases, and that allowed us, I think, to at least concentrate the model. We were then a Department of Health and Human Services, and for the reasons I flagged, that was a good thing. We've got highly responsive health services, and we have publicly funded community health organisations and primary health networks with GPs. So although we hadn't built a fully integrated healthcare system, there were good relationships to start with. We had good leadership in Victoria. The picture there is our Chief Health Officer and our Premier, and they fronted the press every day for more than 100 days in Wave 2, took all of the questions, and had a fairly good pragmatic approach to, as we learnt more about things and perhaps as we learnt about masks, that leadership was very useful, I think, and really helped us keep moving forward. The other things to bear in mind in our favour is that most cases you can manage remotely if you look after those other things, and that reduces the risk to both hospitals, staff and to other patients in hospitals. We had funding models in place for the public hospital system. Telehealth's already funded and looked after. The hospital in the home for people who are a bit more unwell, that's already got a funding mechanism as well. So home-based care we didn't have to invent new funding models. We had to do a bit of work in our community health sector. So we stood up the COVID positive pathways with our health services and with their community-based partners. What does that look like? People were frequently checked in on. We made sure we looked after other disease they might have and kept an eye on the rapid deterioration, because although generally comorbid people deteriorate more and well people deteriorate less, there are still cases of 28-year-old healthy university students and people who can deteriorate quite quickly and need admission. So we had to keep an eye on them. This active in-home program really did reduce presentation to hospitals and took the pressure off not knowing what was coming through the door next. And when folk did deteriorate and need to be admitted to hospital, we were able to put together a kind of a controlled planned admission, manage that a lot better. Over the period of Wave 2, we learned a lot more and were able to put in place the health, welfare and social supports. And in addition, 700 cases a day, our public health officials really were struggling. Hospital clinical staff also stood up to do the clearance from isolation that's typically done by public health staff, and that really made a difference. So here's what the pathway looks like, left to right, lots of points of presentation. But once a case is notified, we got that information to health services and they would do their assessment of the case. They would look after them, and about 70% last year went into a low severity pathway and about 20% went into a medium severity pathway, which was more like hospital in the home, more intense, really virtual ward based. The low severity ones might be referred back to their GP if their GP was up for it and available, or our community health organisation looked after them. And in regional Victoria, the hospitals added that telehealth on because the burden was low. We saw about 10% of cases admitted last year, and that's playing out differently this year with high rates of vaccination but different behaviours of the Delta virus. And so this model of our primary care and community-based looking after most of the cases, but working with a virtual ward of more hospital-based staff with access to respiratory and infectious diseases specialisation was new, and it worked pretty well, and it looked different in different parts of Victoria because health services look different in different parts of Victoria. We're really lucky that we had a National Clinical Evidence Task Force, we have, and that meant that the pathways and the stratification had the best evidence available. That was kept up to date, and they're still working really hard on that. That meant that when we do the clinical risk stratification and the social assessment, we had good guidelines around that. Our Victorian Clinical Leadership Group just did an assessment and top and tailed that. And so we were quite comfy that we had good, robust mechanisms for stratification, and that really made sure you got into the right pathway. So the model of care we're describing then is basically our community partners and our acute sector partners working together with social care providers. Now, that sounds great, but there's a lot of hard bits in doing that. What was hard? First of all, the pace of stand-up was really, really hard. Secondly, we don't yet have a joined-up health system, but in addition, that key piece of information, who's got COVID, that's notified to public health units, and that information is collected under different legislation and arrangements to healthcare information. So we had quite a bit of work to get information quickly to the health services who had COVID in their catchment. We hadn't worked that way before in Victoria. We had 19 labs doing COVID testing, and that meant there's 19 places where that information was available outside of the public health notification. And then how do our primary care providers and our hospital-based system, how do they share a record and share it in near real time, not retrospectively? That was really difficult, and we have a heterogeneous health IT environment in Victoria, so there were quite a few challenges. Just going to walk you through a little bit what that looked like. And I'm doing regional Victoria first, although it had a relatively low caseload, so you can see this is roughly the size of the UK, probably a little bit bigger, lying on its side. But we have 5 regions in Victoria, and they're characterised by a large regional hospital, Geelong, Ballarat, Bendigo, Goulburn Valley and Traralgon. And they have a leadership role within those rural alliances, and they really managed most of the cases remotely. And in rural Victoria, where someone needed to be admitted, and remember numbers were very low the further you got out from the metropolitan area, they'd either be admitted locally or to that regional hospital. Down the bottom you can see a white bit, and that's basically Melbourne. And Melbourne's got most of Victoria's population, and it's got quite a number of metropolitan hospitals. So for this program, we weren't using the specialised hospitals, but pretty much all of the other mainstream hospitals were being used, and they stood up programs with their local partners. It was a really gratifying response from a health system under stress. So if you can picture then, we have cases being notified and we have a health team picking them up. They'll do an assessment and then they might refer them to a community health partner or a GP to look after them, or they might keep an eye on them much more closely in a virtual ward, and some of them they brought in straight away. So some of the way this played out, and we didn't plan this, there's just a couple of examples I'm going to show you. Being able to support a pregnant woman and monitor her oxygenation in very late stage pregnancy while she had COVID was really, really important. And in this case, she was actually admitted to deliver the baby safely on day 8 and returned home with all of those controls. So we're able to do that because she was being supported on one side by a hospital team ready, and on the other side by folk who are keeping an eye on her. The second case is probably more interesting and very difficult. So like in lots of parts of the world, we have culturally and linguistically diverse communities. The language of the nation, in this case, English, isn't necessarily the language of many of our vulnerable patients, and it's a much more challenging situation. So this was a person with diabetes, quite anxious, and with COVID at home. So once we were looking after that person with the program, apart from keeping an eye on the COVID, there are all these really scary practical issues. I've run out of my diabetes strips. I'm not sure about the medicines. How do I get the farms? You've got to stay at home. And with an interpreter and a nurse, we're able to work and manage her through those without needing to admit her. At one stage, she did report breathlessness, and by wrapping some remote care around her with a translator, she settled down and didn't need admission to hospital. That's a good thing for the patient, and it's a good thing for both the patients and the healthcare workers in hospitals. So the third one, again, we had a more, complex case where we were, again, supporting a patient with a telephone interpreter, and struggled a bit with next of kin and making that decision, do we call people in or not? So Ambulance Victoria, our colleagues stood up. Sometimes they'll go and do an evaluation and sometimes they'll bring the patient in. But in this case, we were able to assess the patient emergency department, and then after a couple of days send them back home again into the program, look after them and liaise with the family. So they're just kind of some of the real examples of the complexity of looking after folk, particularly vulnerable folk in our population. So over the last half of last year, the program ramped up while the numbers ramped down. So at the end of it, we got to a position by Christmas where there were almost no cases in Victoria, except people coming in a controlled environment from overseas in quarantine. So then we started to look at the lessons. And there's a couple of areas that were really interesting. So when you share care between primary and acute sector, but it's real time, we're not really geared up for that yet. We stood up some interim systems so folk could both look at the same record, but they weren't really a fully integrated care program for that patient. Secondly, you can worry a little bit about clinical accountability. Our health services stood up and took the accountability with their primary care partners, but that could be tested and challenged if things went pear-shaped and you really needed to get a better handle on accountability. We have different silos of information collected under different arrangements, and with the virulence of COVID, you need to move quickly, and we need to do a little bit better in that area. And we need to get more immediate access to pathology results. The GP involvement was great, but we had to wrap around an out-of-hours thing for folk who did deteriorate out of hours. So quite a lot to learn there. I guess the last bit, I'm just going to close by talking about stabilising this model in around January and where we've got up to since then. So pretty much from January to June in Victoria, we had very, very, very few cases. We went back, looked at the model that was set up by the health service, and they're, of course, struggling then with keeping teams with very, 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 very low volumes. So the programs didn't stand down, but they were folk with other responsibilities and then standing ready to stand up. We learned a few things. We are trying to work through some of those, particularly the information sharing and the shared information systems, but they're not things that can be done quickly. The postscript, I guess, for colleagues is that since we submitted the abstract and since we did an evaluation of the program, learnt our lessons, we have in the last 6 weeks in Victoria gone into the Delta wave. And unfortunately, as you can see up there, our numbers have gone up and up and up. So today we had 208 cases notified. That's a lot in Victoria. We'd had months of noughts, and we're expecting to see those kind of numbers for a little while. So what does that mean? It means that we are rapidly reactivating the COVID care pathway. We have to make sure there's enough capacity, and we're being a little bit more conservative with folk who do need admission, trying to pick them up a bit earlier so that there's not a flashing light scenario. That's an overview of our program. I would like to thank you very much for supporting us in looking after this, and we'll catch up a bit later on to take any questions. Thank you.